All right, welcome everybody. Today we're going to be talking about understanding AEM in HTM. So we'll define what AEM is and go through a number of different aspects of that. But we're going to look at the risk, requirements, and results that you can analyze from this. Just a little bit about me, Joe Stockman. I'm with FSI. I've been 22 years now with FSI, but almost 30 years in the healthcare CMMS space. So I had a prior stint at Fort River Software. Some of you might use TMS or be aware of TMS, or that was back there over 22 years ago. That they were based out of Pittsburgh. FSI is also based out of Pittsburgh. I'm now out of Orlando, Florida. And what I do as in the product role is work with customers to just find out what their problems are, find out what their hurdles are in just day-to-day life, not necessarily with software, but if we could do something with software to help you manage your day-to-day activities or report or get analytics or prepare your documentation, that's sort of what my role is at FSI. But I was actually the first employee of FSI. I spent over 10 years doing asset inventories. We talked a little bit about that with some people at the happy hour last night, and just walked millions and millions of hospital space, square feet of hospital space, doing that. So lots of experience just in hospitals and with the software. So what we're going to talk about today is understanding the risk and regulatory requirements around AEM and OEM. When do you do both? What do those terms mean? Analyzing data and justifying AEM on eligible assets. So there's some things you need to do in your world to make that happen. And monitoring and documenting, and that's the key word. We're going to probably say that word a lot. Documenting your AEM program for regulatory inspectors, depending on which one you're using. So we're going to start with sort of defining AEM. We're going to look at exciting Joint Commission code. So we're going to look at some of that as well. Then we're going to look at how do you set up an AEM program? Do you have one in place now? How do you define your policy? And then we'll see what we need to do to keep that in place. If something happens, do you have to change your AEM as you're going through it? But we're going to start simple. What is AEM? And we're going to define a couple different preventive maintenance approaches when we talk about that. So, when OEM, we'll start with that one. Original equipment manufacturer. So that is the book that comes with your equipment. You're supposed to do everything in that guide, the manual, to maintain that piece of equipment. And what that means is, to the letter of the law, that's, you're doing that. You're using their parts, you're using their frequencies, you're using their procedures, and making sure that you're keeping that equipment safe for patient use. Similarly, if you're, we're talking specifically biomed, but think of a car maintenance as well. You're going to use, you're going to do the oil change every, old cars anyway. I don't even know what the new car rules are, but every 3 months or 3,000 miles, whichever comes first. That was sort of the basic rule around that. Some people do it, if you use a better oil, you can do it every 6 months instead of every 3 months, and that's AEM for all intents and purposes. And AEM is alternative equipment maintenance. That means you're doing something different from what the books say that you should be doing. So like I said, it could be a different frequency. It could be using a third-party part, not the original manufacturer's part. It could be a number of different things. So there's also a couple other maintenance strategies. Reliability center maintenance. That's more of a, doing the analysis around when do you perform preventive maintenance on a piece of equipment. What's the right time to do that? Mostly used in the facilities world. There's some more restrictions around it on the biomed or HTM side. There's also predictive maintenance, where the equipment, or condition-based maintenance, where the equipment tells you, hey, you need to change this right now. And we're seeing more and more of that, particularly on non-high risk equipment. We'll talk about risk as well. And then run to fail, that just means you use it. When it breaks, you're throw it away and buy another one type of thing. So you're not really, you repair it and get it back in service. The cost of doing maintenance, the reason for that is the cost of doing maintenance is, if it's more than the equipment costs, it's not worth it. If you're going to spend 2 hours a year, paying somebody for $100 piece of equipment, that's probably you're going to spend more than that is on that equipment as you go through. So also created with some AI. If anyone likes AI, I created the cool Stockman Medical Center in a storm. So that was I was bored on a Friday afternoon when I was putting this together. So as we talked earlier, original equipment manufacturer. These are the you're following the guidelines. Wow, this is really small up here, by the way. And recommendations provided by the equipment's manufacturer. So when I pulled a couple screenshots of some manuals, but basically that means you're going through these manuals. If you're putting your procedures in your CMMS, in your work order system, you're either copying and pasting those into the procedure or referencing these manuals or having PDFs of these manuals uploaded into your CMMS so you can reference them. But that means that's what you're doing to that equipment on a regular basis. So, if equipment's under warranty, there is something to note there. If you want to keep that warranty in place, you might want to wait till after the warranty period expires where you start doing AEM on that. So you might void your warranty if you do something outside of the norm. So something to keep in mind there when you're doing that. Alternative equipment maintenance, like I said, this is what refers to using parts and services from different manufacturers, not the original manufacturers. I recently had a shower nozzle or the handle go out on me. It stayed on, so I just had, the shower would not turn off. So I had to buy a Moan cartridge to just replace the cartridge in the shower. And there was one for the Moan one was $57, and the Lowe's brand was like $38 or something. So I bought the Moan's one. I'm like, I'm not, for 20 bucks, I don't know what this part is. I don't know anything about it. So I'm going to use the OEM piece of equipment. Had I bought that other part from Lowe's, I'd be doing AEM, an AEM repair on my shower nozzle. So, but the key here is you don't want to compromise the equipment's performance. If you're doing things that might make it unsafe, might put more risk on a patient, like I said, using a subpar part or doing the frequency, they say to do something every year and you decide you're going to do it every 5 years. That's probably not going to keep that equipment running properly. But if there's data behind that, you could. And that's what we're going to talk about as well. So now for the fun part, we're going to talk about code language. So I'll try to make that, I'm glad I'm not the 8 a.m. session, because this would be, you guys already had enough coffee already. But before we get into the code language, we're just going to talk a little bit about some of the agencies. Joint Commission started doing this in 1951. I was trying to find, when I put the slide together, just a little behind, I was trying to find the percentages of hospitals that used each one, and you just can't find that anywhere. So if anyone has that, email it to me. There was one called HFAP. They recently, in the past couple of years anyway, became ACHC, American Accreditation of Hospital something. I forget what the acronyms mean. And then DNV's been around a long time, but they've only been doing hospital accreditation since 2008. So actually not very long for hospital accreditation. And there's also newer on the scene is CIHQ. They're out of Texas. They're trying to build their brand up as well. So, but I do have a question, just to show of hands, who's using Joint Commission for your accreditation? DNV. Oh, there's a nice. That's probably my biggest percentage of DNV users. ACHC. Any ACHCs out there? I see a couple scattered around. A lot of them are switching. Anyone using CIHQ? You would have made 20 bucks. I have a thing with myself. If I ever see a hand go up for CIHQ, I'll give them 20 bucks. And then there's also other authorities having jurisdiction. So if there's any state agencies or county agencies that you have to adhere to, you have to keep that stuff in mind as well. So, but Joint Commission is usually the biggest player. They have the biggest percentage. I can't prove that, but I'm pretty sure they do based on my analysis. And their stuff currently lives in ECO 20403. is where a lot of the medical equipment stuff lies. DNVs is in the physical environment 7 chapter. And then, as hopefully you know, if you don't know, sorry to break it to you, but the Joint Commission is changing the standards starting January 1st. So this, I did not have a chance to update this presentation. They were just published a month ago, and they're putting out crosswalks, and they're communicating sort of what those changes are going to be. But for the most part, you're doing the same things. You're just reporting on them differently. And there's a lot more references and rabbit holes to go down. Has anyone started digging into the changes yet with Joint Commission? Everyone wait until December? Yeah. Yeah, yeah, it's not even finalized yet. They're gonna have it truly finalized in September, and I would look for a lot of revisions in the next year or so from the people I'm talking to. It's like there's so many vague areas that it's so just be careful with what you're doing. So and like I said, the 2 big ones are Joint Commission and DNV. So so we're going to look at sort of, we're going to start from CMS. They all start with CMS, the Centers for Medicare and Medicaid Services. Probably some of you may have never seen this logo before until recently in the news. I think this year there's a lot of eyes on CMS. There's lots of presentations on the news. It's making a lot more headlines on the news these days. But this is the SNC 1407. If you do get a copy of this presentation, that is a link. You could actually click on that link and download that document. It's just a couple pages long, and it really tells you, and I'm not going to read this whole thing, but it's really defining what a medical device is. You have to start at the top. What is a medical device? And it refers to devices intended to be used for diagnostic, therapeutic, monitoring, care provided to a patient by a hospital. So anything that, like you said, monitoring, diagnosing, treating, all those things are what constitutes a medical device. So even the language, they're trying to be a little bit more defined in what they're talking about. So it all starts here, and whether you're DNV, Joint Commission, they write their specifications towards CMS. They're ultimately governed by CMS. CMS checks up on them. That's one of the reasons for the Joint Commission changes, from my understanding, from the hearsay out there in the industry, is as Joint Commission went far beyond what CMS was requiring. So in other areas, not just biomedical. So they're sort of trying to align it more with CMSK tags, with the language. It's interesting that they're removing the environment of care and life safety chapters and replacing them with the physical environment chapters, which is what DNV has. So if anything, they're going to be aligned more with DNV. Anyone here considering switching from Joint Commission to DNV, since you kind of have to update everything anyway? Oh, they're going from DNV to Joint Commission? It's interesting how some as hospital systems combine too as well, they try to, if you have a mix, that makes it tricky to have something for the entire organization. So that's a reason behind it as well. So cost. I never thought, yeah, I don't know I have no idea what it costs to have one of them come in. So is one cheaper? Yeah. Yeah. A lot of people say DNV. Has anyone used both? They say DNV is nicer. That's like one of the, they don't feel as under pressure from DNV as they do from Joint Commission inspectors. It's more like they're partners with you than just like yelling at you. I don't know. They're not really yelling at you, but that's sort of where they are. So we're going to start off with EC 020401 EP4, and it's about managing medical equipment risk. So risk is a big important part of this. Defining what equipment's high risk, what equipment is non-high risk. Notice they don't use the term low risk. There is always a risk. They don't want to sort of weigh it. In fact, that there is some risk. If you say low risk, that sounds bad. But the key piece I want to pull out of this EP is, since we're talking specifically about AEM, is the AEM program, again, must not reduce the safety of the equipment. And that's right in the Joint Commission Code language. So that's the goal, and that's your goal too. You don't ever want to do something that's going to put a patient at risk. That's why we're all here. That's why we do what we do, keep the patient safe with the equipment that we're servicing. Also, as you're defining your AEM program, if you're have the associated frequencies, whatever you define, you must have 100% completion rate. So that's something to have note as well. There are some ways to do that. I did another talk, I think at the HTM mixer in Denver, and then also at the MD Expo earlier this year on unable to locate assets. And how do you, if you're unable to locate, how do you maintain your 100% rate? So those should be online somewhere, but there's some tips and tricks there on how do you get to that 100% with your unable to locate strategy. That's a different type of strategy for percentage reporting. It's all about maintaining statuses and documenting everything you did to find that equipment. But the key here is the frequency is determined by your AEM program. So when you're looking at your AEM program, as you're putting your AEM program together, you, or the hospital, maybe not you personally, but you as your organization are determining the frequencies for that equipment based on history, industry standards, what other people might be doing. So we'll talk about that as well. And that might help you if you're not hitting your 100% completion rate because you just have too much work to do. If there are some things you can do less often, you can hit that 100% rate. So going into 02, 04, 03 EP2, defining high-risk equipment. There's a risk of serious injury or death to the patient. That's what's defined as high-risk equipment. If you have a scoring strategy for risk, that's usually one of the factors that automatically just puts it in the high-risk category. There might be some other ones in there. We'll take a look at a risk strategy here later on. Scheduled maintenance activities for high-risk equipment in an AEM program. You can have high-risk equipment in your AEM program. It's not limited to just non-high-risk equipment. You can have an AEM for high-risk equipment, but again, you still have to have a 100% completion rate. EP3 talks about non-high-risk equipment. Also, still has to have a 100% completion rate. So, when you're defining your strategy, when you're defining your risks, just make sure you have the resources available to hit that 100% completion rate. And again, the frequency is determined by the hospital's AEM program. So some takeaways from here, they're a little vague in some of them. They sort of just give you these paragraphs on how to do it. So your policy is designed around that. But again, you determine the frequency, and it's not just pulling it out of thin air. There's data behind it. You have to score the equipment, whether it's high risk or non-high risk, but make sure you're reporting on both, but make sure you're also hitting 100% on both. And then, to get that 100% completion, one of the ways to do that, and one of the most common things to do with AEM is you're not really changing the procedures you're performing. You're still doing the same procedures, but mostly what you're doing, from what I've seen, is using different parts for one, and decreasing the frequency. Decreasing the frequency is the most common change to make it an AEM strategy. So. Say that again? Are there certain types of equipment you cannot have in an AEM program? The answer is yes. We do have a slide for that later on down the road, so we will talk about that. So there are some things that's like, nope, you can't, you have to do this, you have to do OEM on these ones. We'll have some examples of those later on. I just had to take a break from all the code language. So I see some people falling asleep, so I rearranged my slides so we can continue about that. But great question. I feel like you knew the answer to that. So the program itself, the program is a strategy used primarily in healthcare. That's where we're doing this. to maintain medical equipment. Unlike traditional maintenance programs that follow a strict calendar-based schedule, AEM programs are more flexible and data-driven. So we'll look at some examples of how we got to some of the changes in building an AEM program. So again, it's a data-driven approach. We use historical data, equipment usage, failure information, performance history, maintenance logs, everything you document on that equipment. You should use that to build your AEM program. And it's not just a simple AEM program. There's a lot of work that goes into justifying these things. But the biggest reason is cost. If you're doing everything to the letter of the law, if you will, or to OEM standards, sometimes that's very expensive. I was recently looking at an ice maker for my house, and it was like, one of those little countertop ones, and I looked at the OEM recommender, it was like after 8 hours of usage, run vinegar through this, do this. I'm like, I can't do this every day. Like, this is ridiculous. So I did not buy one. I'm like, that's too much work. I'm not gonna do that. That would be costly to me for my time. I don't want to spend every day or two like flushing it out and running it through and make sure my ice doesn't taste like vinegar. So I chose not to use that equipment. You don't have that choice with some medical equipment, but as you're spending lots of money, people are expensive, their labor hours are expensive. If you're trying to meet that 100% requirement of completion, doing all OEM, it's probably going to be more expensive than if you're doing that with AEM. So cost is the main reason that the hospital is interested in doing that. If you have enough people and you have all the resources in the world to bring, who has that problem? Anybody? I like to ask questions where people don't raise their hands, so it's that's how I. But no, that's the primary reason for it. It is risk-based. That's going to be a factor in that. Like for high-risk equipment, you want to really make sure you're doing the right thing. I would say most people are putting their non-high-risk equipment. There's more non-high-risk equipment in the AEM strategy than the high-risk equipment. But like I said, you can put high-risk equipment, and then also you want to make sure you're compliant. Your programs must comply with the regulations, those set by CMS, Joint Commission, which now I just heard it's not the Joint Commission anymore. They took the away, so it's just Joint Commission. They're trying to be strict on that. So. And then DNV. I was just at a talk with them earlier in the week. They did a talk on some of the code changes coming up, and and quit calling us JACO. Like that's like so long ago. Like don't call us that anymore. Anyone call them JACO still? Some people still do that. That comes from the Joint Commission Accreditation of Hospital something. It was JCAHO, Healthcare Organizations. It's so long ago I don't remember, but thank you. But people somehow, JACO, it became it doesn't look like that. So don't call them that. Like, if you're getting inspected, oh, no, JACO's here. Don't your immediate mark on your record there for that one. So let's talk about setting up your AEM program. And we're going to look at a sample one, a sample policy. Remember, this is your policy. We're going to take a look at what's in it and what should change it. I put this together for the AMI show with one of our customers, who used our product to help set up the AEM program to get the data around it. I asked him if he can come up here to do this with me this week, but he couldn't, so it's just me up here. So I'm going to be doing some of his parts as well. So we anonymized their policy just to take names and department names out of it. I don't expect you to read this. We're going to walk through some of these things in here, but this is their AEM policy that they have written. There's a sort of a purpose of it, and we'll go through each section, some definitions, what the policy actually states, and then there's references to the CMS document. So I put a couple slides together where we zoom in on them a little bit. So again, just some formatting. You don't have to make it look super formatted. Probably put it on your hospital's letterhead. But the purpose, a purpose statement of why you're putting this policy together, and what the scope of that is. If you have hospital facilities, if you have critical care facilities, if you have long-term care facilities, you have different types of facilities, you might want to put what this covers. If you're doing AEM across them all, We just put all facilities here, but you could have different policies for different types of structures. So as you're defining the structures and as you're looking through the code, make sure you're following the relevant code. We're mostly talking about hospitals here, so but codes could be different in different types of facilities. Not so much for medical equipment, but for other types of equipment as well. So if you have other departments that are using AEM, such as facilities engineering, just make sure you're aligning your policies, that tweaking them together, work with them to come up with a policy that might encompass both. So you could put those together, follow the same guidelines, follow the same data formats that you're using to justify these things as well. So there's some definitions. There's a lot of acronyms that we're using. So just as you're putting your policy together, probably mostly for leadership, senior leadership, that might not be aware of all these different acronyms and the things that you guys do guys and girls do on a daily basis. So we're just defining what is AEM, what is a CMMS, what is CMS. They're very similar. They're both in your lives, so they're very similar in name. What's the EOC, the environment of care? What is a medical device? They actually put that right in their policy, defining what a medical device is, what medical equipment is, and the medical equipment management plan, and then finally the OEM, the original equipment manufacturer. So just a period of a section of definitions. So out of that 3-page policy, a lot of it is just defining what these things are. The policy itself, as I said, don't squint. I made a couple slides on some of these other ones too, but we're going to go through what these are as well. So part of it is defining risk. So all electronic medical equipment within the program will be risk scored. Whether it's under OEM or AEM, we're going to do a risk score on that piece of equipment, and we're going to build that. They're going to document that in their CMMS. That's where they're doing that. Your CMMS should be your single source of truth for all this type of information. You should have your policies. You should have your risk strategy scored by either each piece of equipment, category, manufacturer, model, whatever you're doing, however you're scoring your equipment, you could build your risk strategy. We chose to show an infusion pumps risk strategy, and here we have a strategy where we have different questions, sort of what the equipment's function is. It's therapeutic. We talked, is it diagnostic, therapeutic? That's going to, again, increase the risk. So that has an 8. So the more, when it's therapeutic, it has a higher number than if it's just a monitor or something like that, which still might have a risk, because if the monitor fails, you might not know something wrong with the patient. Clinical application, what the requirement is on the piece of equipment, whether it's annual, monthly, and they built, this is their strategy, by the way. I don't know if does this look familiar to anybody? I'm not familiar if it's a common strategy or not, but that's the one they put together. Likelihood of failure and environmental use, where you're using that type of location. So the location you're using that equipment might affect what your risk is on that piece of equipment. So there might be a higher risk of failure in different locations in the building, if it's used in ICU versus another area of the hospital. So those are things to keep in mind. And if you need to go to the asset level, these particular pieces of equipment or assets are in this department, and these ones are in a less risky department. That might affect your strategy as well. And then you build the formula, the mathematical equation to get there, and it comes up with a risk score. So a lot of people have done this on spreadsheets, a spreadsheet with the different values in it. You write your formula in Excel and somehow apply that number to there. But again, you have to have that documented, how you came up with that number. You just can't say, oh, this is a risk of 13.3. And well, how did you get that? You want to have the means of how you got there documented somewhere. So again, document and know where it is. know where you documented. That's the other important part. So I think we anonymized it. It might have had a different name, but the Biomedical Engineering Council is the group within the hospital that determines, that makes the judgment, I guess, can something be AEM or not? So if they agree that, as you put all this data together, that it can be AEM, they put that in place, and that's how this hospital does that. with their work. I don't know how anyone using AEM with a documented strategy? All right. So a similar type of thing, you have a review board or some group of people, someone that's deemed, probably not deemed isn't the right word, but has the knowledge, they're the right person to make that determination. The Joint Commission is getting more strict on that, making sure you have credentials behind it, that you have the skills to determine something like this, and it's not, just somebody, a lower level, new tech that put all this together. You do have to have the credentials behind it to do that. But is it a group of? Is it one person, group of people? Okay. Okay, Service Excellence Committee. So. A mix of people just to make sure you're not missing anything. So perfect. Yes, ultimately, yes. Everything you put in, again, documentation. You need to have that attached to the documentation. If you're doing it by model and saying this manufacturer model combination, we are going to use AEM, where do you document that? Do you have somewhere to put that links it to the model numbers, links it to the assets? Is it accessible from those assets? Again, you want to make sure all that stuff is available, easy to find, and you know how to find it. And that documentation should include the risk scoring and the data that justifies that. Like if you have data that says, hey, we've been performing PMs on this piece of equipment for 5 years, have had 0 failures, have that documentation available as well. And again, maintain a repository of records to support your AEM selection based on your work order history, also industry standards and other recommendations from accreditation agencies. So it could be something outside your organization. It's usually not, but it can be. Most of the data we used to put this policy together was from all internal data. They didn't want to go outside. Again, different environments, different people doing PMs. It's your yeah. Yes, you can use published papers. You need to monitor them. We're going to talk a little bit more as we go through this, but once they're in the AEM policy, you need to monitor and make sure that you put this in place and it's still working. You're not having the failures and those types of things. You do want to make sure you're reporting on that regularly and documenting that regularly as well. So if you put your AEM policy in place 5 years ago and your documentation from 5 years ago, and you never did that analysis again to say, hey, this is working, can we tweak it again? So make sure you're documenting as you move forward too. So you're not done when you say, oh, we've put our policy in place and now we just do everything once a year and take the rest of the year off. I know you still need to document all that stuff. So again, the determining of timing, testing performance, testing frequencies, parts, must be made via qualified personnel. So that was the word I was looking for earlier when I was a little bit absent-minded there. But again, you need to make sure somebody that's qualified to make that decision is making that decision. So that's an important part of it as well. They specifically called out the classification field. This is our, we have a classification in our CMMS as high risk AEM, non-high risk AEM, then high risk OEM, and non-high risk OEM. So we make that determination. You could actually determine whether something's high risk or non-high risk based on the number. So there's a calculation of whatever that number is, can automatically throw it into the high risk category for us. They're manually, as they put things into the AEM programming, and switching it from either the non-high risk OEM to the non-high risk AEM. So, and that goes, that's how you sort of group all the equipment together so you know what you're reporting on. And that goes into the code language where you're looking at 100% completion on, instead of trying to search by risk number of the equipment, our work orders have that classification on it as well. So we try to group them into four buckets of work for the most part. What they also did was made an evaluation form. So they sort of took all of this stuff that we sort of presented and made an evaluation form. This evaluation form is what they're using. So when they're saying, hey, we want to take this type of device or this manufacturer model number and put this in our AEM program, they have a form that they fill out, and that ultimately goes to the Biomedical Engineering Council or your Services Excellence Committee or whatever you call it, your organization. And then once it's obtained, they document that, somebody signs off on that from that committee. That's probably your qualified personnel that made that determination. And again, it references that document that I showed earlier from CMS. So what that evaluation form has, as an example, I know it's a little hard to read, but it includes the device type, model, and how many of them you have at the facility. So if you have 100 or so of these devices, it's going to apply to all 100, 1,000, however many of them you have. It incorporates the excluded equipment. So in their policy, we'll show that bigger later, but it has, is this device a medical laser? You could kind of read that there. Well, don't look into the light. You can see if it's a medical, that's one of the excluded devices that you were asking about earlier. If it's a medical laser, automatically it's going to, nope, can't do this on the AEM program. Ask about past incidents. Has this manufacturer model had past incidents, and what are they? That's going to help determine, can it be in the AEM program? There's also some language around new equipment. If it's something brand new that just came out, you can't put that in your AEM program. Nobody knows if it's going to, you want to follow OEM until you have some data behind it where you can put that in. The gentleman I put this together said they go at least 3 years before they even consider it. So when something comes out, it's at least 3 years. They have 3 years worth of data. That's not, I see some heads nodding. Is that about right? What you're doing with new equipment before you're looking at it? Uses risk and calibrated required OEM parts. Like if there's something that requires OEM parts, there's a question regarding that as well. Again, if it's allowed to be in the AEM, document the changes to the procedure and the schedule. So there's a component there just sort of to remind, like once it's approved, go ahead and change your frequencies, go ahead and change your procedure, go ahead and change the parts you're using, whatever the changes are to that AEM item, that's what you want to go ahead and make the changes in your CMMS. Like I said, sign off on it, put that document in your CMMS, link it to the assets, link it to the manufacturer model, link it to the category, wherever you need to have that. Again, make it readily available so you're not scrambling to find it later. Don't just put it in a drawer somewhere. Have it electronically available as well. That would be my recommendation. So, anyone storing their documents electronically like that now? Linking them to, good, couple hands. So going back to the Joint Commission behind some of those things there, like I said, I gave you a reprieve from it. So 02041 EP5 basically says these types of equipment you cannot put in your AEM. I should have maybe used a red highlighter or something along that. So medical lasers, that was the one I called out earlier. Medical lasers, you have to do OEM parts, OEM frequencies. So make sure you're doing that. So imaging and radiologic equipment, whether it's diagnostic or therapeutic, you can't change what you're doing. You have to do it per those manufacturer's instructions. And again, the new medical equipment that does not have that maintenance history, something just came out, there's no industry standard or recommendations around doing something different. You want to have some period of time. Like I said, 3 years is a good ballpark number. But that's when you first consider that for your alternative equipment maintenance. And particularly in the biomed, the HTM world, seems like there's always something new coming out. I've never repaired equipment, but I don't know how you guys keep up with all the different changes in the equipment and the new things. I think I heard one of our sites, you had like, at least 4,000 unique different pieces of equipment that they have to maintain and do PMs on. And it's, that's another reason for AEM as well, because to follow it for all of those, tricky. A lot of people are just buying stuff to be the same. So it's the same type. So that's another strategy as well, is to, sort of align your equipment. But some, if you're a new hospital with money that can do that and replace it with all the same types, great. Some hospitals don't have that. Some are getting hand-me-down. And also look at, as you're getting rid of that equipment, donate that equipment as well to some organizations that can use that stuff. So documentation we talked about, that's the only thing I highlighted on this slide, but make sure you do have documented evidence. And so we talked about documentation. So if you have contractors coming in, so you have, GE coming in and doing your, I don't know why, they're a GE Health or another non-GE vendor coming in and doing some of your PM preventive maintenance, or make sure you have that. Make sure you have that. Make sure they give you the records. You don't want to be and store those in your CMMS as well. I'm sure they're emailing them to you or sending them to you in some way. Make sure they're documented and easily available, easy to find. As you're looking, going through your inspection, whether it's DNV or Joint Commission, you don't want to struggle in finding them. I think they're starting to put time constraints in some of their policies and procedures around how long you have to provide documentation. So they're starting to be a little bit more strict on that too. So just to be aware, they get annoyed if you annoy them in document review. They'll be more annoying as they do the physical tour of your hospital. So and that comes right from one of them saying that. So make it as comfortable, as seamless as possible. So if you have all that stuff readily available in your CMS or in binders, we still have customers that have the wall of binders behind them for different things. If it's easily available, it's right, you're doing it right in that room, perfect. Just make sure you have it, you know where it is, you practice, you know where all that documentation is, and that qualified individual knows where that stuff is too. That's something as well. Like, well, you're not the right person for this. You're in charge, so you show me where all this documentation is. So I've heard stories of where they're starting to put that person in place, and I know some people in those positions are far removed from that, but make it easy for them to find that stuff as well. So if you are using information made public by nationally recognized sources, make sure you have that as well. So where did that come from? What are those case studies? Put those things in. And then obviously, what most people are doing is using their own documentation. Here's our history with this procedure. Here's our history with this frequency. And here's why we changed it. If you have graphs or things or documents that show you the failures, that's what you want to go ahead and document. So EP6 does talk about the qualified individuals for deemed statuses, and a deemed hospital is just one that is getting reimbursement from CMS, Center Medicaid and Medicare Services. That is a deemed hospital. I think other hospitals are following these as well. Usually, oddly, the government hospitals are not. So VAs and those hospitals are not deemed hospitals. So I found that interesting. I just learned that. So, but a qualified individual uses that criteria to support whether it's safe to permit medical equipment to be maintained in an alternative manner. So how that's used, some pieces that are used, and this is the code language too. This is sort of what it all boils down to. And if what is the seriousness? So what's likely to cause harm if I'm just using this regularly? Can it cause harm if something goes wrong? How likely is it to fail? And again, if it fails and there's more risk of harm, is it something that's likely to fail? Is it a complex piece of equipment, something that's been around a while and it's pretty straightforward to use? Can electronic components go? Does it blow fuses a lot? What are the history behind that? Do you have backup equipment? That is also a risk thing. So if one of these breaks, do you have another one? If 10 of these break, if they break over time, do you have 10 more, 20 more? What do you have for backups on these types of things as well? Any incident histories, that's something you do want to make sure you document. So if there is an incident around a piece of medical equipment causing harm to a patient, and it's on your AEM program, that's gonna, you want something that's gonna flag that to go reevaluate that AEM program. And then the maintenance requirements of the equipment. If they're monthly for some reason, there's a reason that they're monthly. So how far can you go beyond that? Like how far do you want to take it before, is quarterly acceptable? Is every 2 months? Do you build that over time? Hey, we switch from monthly to every 2 months. Now we're still good. So maybe you can, in 3 more years, you justify that and go to every 3 months. So maybe it's not all at once. Maybe your goal is to get to a much longer frequency. But if you start seeing more failures happen in that time, or more incidents happen in that time, you do want to make sure you're noting that as you go through that. But just looking at some data, again, we anonymized this data. We looked at different hospitals. So, Hospital 1 is our large hospital with a particular manufacturer model number. Their device count was 777. It's a real number, but we didn't change the numbers. We just changed the names. They looked at how many PMs were done over 3 years. How many corrective work orders were performed on that piece of equipment, or those 777 pieces of equipment. How many device failures and they were actually, how many were just due to probes and batteries. So, if one of the pieces is just doing a battery replacement or a battery check, that could be a reason why if you change the frequency, that might happen more if you're doing it less often. So, and maybe you even tweak your procedures to just change the batteries every year and do the maintenance every 2 years or something along those lines. So, again, other device types as well. This one had 1 failure. This one has 0 failures. So, in this scenario, is there any one of these you might not put in your AEM program? If it's hard to see, I understand that, but I just see a lot of corrective work orders on that first one. So that might be something like, might need to dig deeper into some of those corrective work orders and see what we're actually doing on these. Are they, if they're all user errors, that's where you start classifying the correctives a little bit as well. So, is it because of user error or user training? Was it an actual corrective you had to repair the equipment? Those types of things. So some things to keep in mind as you're doing some of this analysis as well. So looking at the total number of devices, we have a failure rate of a pretty low of 0.00035% failure rate for this device. This is one device that they use in multiple hospitals, by the way. So it's something that again, when you put all the numbers together, even though that stands out to me as a lot of corrective work at that one particular hospital, maybe when in the overall grand scheme of things, there's not a lot of failures on that one. So I forget which device this was that we took this data from. So yeah, it's actually percentage of failures is more on hospital 2 if you look at the 1 failure. But yeah. Mm-hmm. Yep, exactly. So, but yeah, the roll-up part though is sort of where like I said, we summarize all that. The same device type across multiple hospitals is where we get the total number of failures across that was 4. I think the screenshot cut off the bottom of this one here when we're cropping it. So we don't have the numbers. There's one. They're trying to figure out why there's 4 failures, and I only see. I don't see that on the one side, but again, the data could be presented simply like this. Like it's a sample. This is the data for that particular device. You could probably even do it across just that top portion. Could be your documentation of your analysis. I'd probably put some date range periods in there so you know how outdated the data is, and do some things like that. But again, we're just trying to anonymize this for the presentation. So it doesn't have to be super complicated. It's data you can get, probably just by running some searches, running some reports in your CMMS for that particular model number, that particular device number. So finally, maintaining your AEM program. There's not a lot of secret sauce in this one. Again, most of the stuff we talked about, you're just doing it again. You're doing it often. But perform and track your maintenance activities. Again, you're documenting those anyway. whether it's AEM or not AEM, you should have all that documentation around what you're doing. Report regularly on each model in AEM. So maybe you put a report together that shows the different models, and here's my 2024 report on how the AEM program worked for this particular model. Here's all the procedures that were done. Put another one of those charts like we just looked at for that particular make and model at the end of every year. So maybe every year you put that together. Report on any hospital safety concerns on any device device models. So if something did fail maybe a little bit more often, you're seeing those numbers as you're comparing those, before you put them in the AEM program till after you put them in the AEM program. Note that as well, and make sure that if there are concerns that you revert back to OEM or tweak your AEM program more to be more strict. I don't know if strict is the right word, but more frequent or more often, or more maintenance activities. Include preventive maintenance in your reporting. Include all your PM reports, but also your failures. Your failures are a big part of reporting. On when a device fails, that's what you want to take a look at. Also include your corrective, your service request work. And like I said, document the type of work that was. If it was an actual corrective where you repaired that versus it was unplugged type of thing, or the plug was loose, or something along those lines. Something that wouldn't matter if it was AEM or OEM. Is usually what you're looking for there. But if it was, make sure you're documenting that. Make sure you have a failure code for that type of information. And then ultimately, when you're looking at those reports, what should I take out of my AEM program? That's a question you want to ask. And if there are things you want to remove them, make sure that's documented in the policy. Make sure it's documented with your service council as well. And you'll probably want to revert back just a couple things. If there's a patient impact exception, something happens to a patient on that particular make and model, you're going to consider reverting back to the OEM. If for some reason the risk categorization changes, so you move some of that equipment to a higher risk area, or something else, you rescore your equipment and notice that it has a higher risk. A different qualified individual comes in and rescores it. That could change your AEM program as well. Or if the code changes, there's a lot of code changes coming up, so keep that in mind. So I picture a lot of policies being rewritten to perhaps reference some of those new standards that are going to be finalized here in a couple of months if they hit their deadline. So hopefully they do. But that's where you might want to revert back as well. So yeah, this is just a summary. We covered these topics on this item here. I'm not going to read through this again. It's just an item here. Just a little bit about FSI. We are a healthcare centric CMS. We have a really high retention rate once people switch to us. We're really proud of this number here. People sticking with us as they like our how we operate and how we do things. We're healthcare focused. We hire from healthcare. Our support group comes from healthcare. They've all worked. The people taking your phone calls and answering your support groups worked in a healthcare environment. We have over 1,200 hospitals using us. We do both facilities and biomed. And we have compliance tools built in for Joint Commission, DNV, ACHC, and we're looking at migrating our customers over to the new standard. So it's just a simple mapping. Well, not a simple, it's a mapping. I won't use the term simple because it's a little bit more involved than everybody thought once they published those. Something about us, we have an annual user conference for our customers. It's free. Our customers come out. This year we're doing it in Denver in October, and it's free for customers. You just have to get there. We do learning. We have a customers talk about our software, how they're using it to do different things. So just a little couple things about FSI. We'll be at the exhibit hall that way, I think, between 12 and 3. So stop by and see us. And then finally, I'll stop and just see if you have any questions. So have a Q&A period or discussion or other. No, we got one back here. Can you speak? I'm sorry. Can you speak up just? Okay. If there's published industry standard data, then you could use that. So if it's new equipment, and the 3 years, I don't think it's published. Like there's 3 years is kind of just like what people seem to think is good. There's no like language that said new equipment has to be in service for 3 years before you can do an AEM on it. That's not there. So you're using your judgment, and 3 years of judgment, 3 years of activities. As long as you have documented maintenance activity, you should be good for that. So. But if it's new to you, it's not new to, and that was more around new equipment, new to the industry equipment. If it's new to you, then yeah, you could use those industry standards, publications. If you came from another hospital, maybe had those that, is that an industry standard? Can you use that in that environment? I'd say, you could try. I wouldn't, but it does specifically say industry standards in the code, so I would shy away from, well, I did it at this hospital this way, now I'm at this hospital. I don't know how that data would work. Has anyone done that, by the way? Would anyone do that? If you went to a new hospital system and take your AEM data from one hospital to another? I don't see any hands going up. So, but if it's new to you, I would say wait and get your own maintenance history on it before you do it. So. You were starting to. Okay. Well, if there are no more questions, you're free to go. Thank you so much. I appreciate it.